slide. Great. Thanks for joining us today. It's Barbara McCaffrey in the top office with Sandy Foss, and the topic is Guiding a Team Through Change, Managing Resistance to Change. So the objectives for today are for an improvement facilitator to be able to recognize resistance and the opportunities that present, respond to resistance with an appropriate strategy, and apply proactive steps for avoiding or reducing resistance. The topics that we'll go through include what is resistance in the overall change management framework, looking at culture versus process change, identifying it, why you're seeing it, dealing with it, proactive steps so that you can avoid it, as well as identifying ineffective methods for dealing with resistance. Sandy will present a case study, and then we will be going to question and answer. Okay, can you put it on pause? Stop recording. Okay, so looking at the change management literature, starting at a high level, there is evidence of what the greatest contributors to success in change management are. Importantly, and this is consistently through the literature, the number one contributor to success is active and visible executive sponsorship. Now, in clinic organization, the leaders would be your physician owners of the clinic, your physician leaders at the primary care network. Depending on the organizational structure, it might be an associate clinic and it might be the entire association. But sponsorship from those leaders is very important. Other contributors to success include open communication, a structured approach to dealing with the change, and that's exactly what the facilitators have with the ASaP initiative, and that's the model for improvement. Having dedicated resourcing for change, and that's the improvement facilitator. Also, clinic team engagement and participation is important, as well as that support from the managers within an organization, and that might be the clinic manager or other people in a management role. Now, when you think about resistance and comfort, the level of comfort with the current state is often underestimated by facilitators and change managers. And I think we have to look at one of the laws of physics, and that's Newton's first law, which is the law of inertia, that states that objects at rest remain at rest and objects in motion remain in motion unless acted upon by a force. And people don't like change, and it's human nature. And as you enter any change initiative, it's important to recognize that it is natural and normal to see resistance to change. But there are factors that will determine the amount of resistance that you will see. A person's individual personal history will be important and what's going on in their life, but also the changes that are going on in the workplace and the amount of change that is going on in the workplace. As we move ahead with thinking about change, it's also important to think about, is it a process change or a culture change that is going to take place? And when we look at Alberta, the Screening and Prevention Initiative, we're really talking about a process change. It's about the screening processes in the clinic. So the question is, will there be also a cultural change? And these are attitudinal changes that might occur with the change. And if there is initial interest to get involved with ASaP, the attitude is there to start the project. But there might be some cultural changes as you go through the changes at the clinic level. And a good example to think about cultural and attitudinal changes are about hand washing. So hand washing is an important concept in medicine, and changing people's attitudes toward hand washing would be a culture change, but actually the way they clean their hands would be a process change. So let's look at managing resistance. First, you have to be able to identify resistance, and that's looking at both verbal and nonverbal indicators of resistance. I think the verbal ones can be self-explanatory. People are explaining why they don't want to do it. We've already done this before. Haven't we already done this? They might be expressing things like this. But when it comes to nonverbal resistance, it might be things like rolling of eyes, sitting with your arms crossed or your legs crossed during a meeting, making hand gestures to show exasperation, doodling during a meeting or when you're trying to have a conversation, avoiding eye contact, or fidgeting with materials. So it's important to identify when you might be seeing resistance with either a manager, a physician, or a clinic team member. So use your feedback tools that you have available to you. And you do have a readiness assessment for physicians as well as other feedback tools that are available in your improvement facilitator binder. Also look at informal feedback tools. Start some conversations around the clinic about the project and see what people are saying. Meetings, formal meetings, can be an important feedback tool as well. So define the resistant behaviors that you're seeing and monitor how often you're seeing them. If they are increasing in frequency, that's an indicator that there may be resistance, but if you're seeing decrease in those behaviors, you're off to a good start. So let's look at reasons for resistance. Number one, this comes up through all the research, is lack of awareness. If people aren't aware of the change or the project and why it's being done, they may be resistant to the change. But often there might be a misunderstanding because they might perceive impact on their workload and time. And you might be hearing this from physicians. If I do this, I'll have less time for patients. And that might be something they perceive will happen as a result of screening process redesign. Depending on their level of involvement, they may perceive a loss of control in the process. Some participants could actually see that there might not be a role for them during the project and could possibly perceive a job loss situation. Something else that will be indicative for resistance is if there has been change in the organization in the past and how that change went. So the past performance will be an indication of how much resistance you might get within that organization. So why do health professionals resist change? There's a great set of resources within IHI Open School during the course Human Side of Quality Improvement. And it delves into why health professionals resist change. And while the information is very similar in some respects to the literature with respect to change management, something that is different amongst healthcare workers is that they seem to have a lot of autonomy and independence, and this would really include physicians and physician owners of clinics, that they want to be able to perceive that they're in charge of the change, and that's an important aspect to evaluate. So in looking at dealing with resistance, an important role for the facilitator is to build awareness of that need for change. And we talked about this during training, that you need to get sometimes some numbers, and that's why baseline measurements and the initial chart reviews are an excellent source of information to show the need for the change. Also, to be able to share how that change would benefit different members of the clinic teams and the organization. And there's quite a few communication tools that you can use. Talked a lot about huddles. So huddles are that daily dialogue, or it's a weekly dialogue to support continuous improvement work. And it's a standing meeting, usually less than 7 minutes long. It's short, it's focused, there's a huddle leader, and it's a quick and easy way for getting people on the same page. Another tool that you can use is your improvement board. And it keeps all team members, including part-time members of the clinic organization or extended members of the clinic team, informed about the change that's going on. A project charter is a very formal piece, but it is a written document that is used to formally communicate all aspects of change to all people involved, including the decision makers. An important step in dealing with resistance is the communication loop. And effective communication requires sending and receiving of messages that includes both thoughts and feelings. It requires a process which flows back and forth between the sender and the receiver. And to remember effective tools in communication, SLUCA is an excellent acronym to remember. So when you're communicating with somebody and you sense that there might be some resistance, first stop, listen with respect, understand what the speaker is saying, clarify your understanding and share your perspective before checking for their understanding, and acknowledge their response. Effective communication is an environment that is conducted within support and candor. So supporting what the other person is saying, but being honest in your feedback as well. In terms of dealing with resistance, another excellent tool that you can look at if you haven't already done it is the course Teamwork and Communication on IHI Open School, which brings a great example on effective communication, and that is the verbal feedback that occurs during times of transition in the hospital. And it's another example where you should be looking for effective feedback tools. So let's look now at dealing with resistance with team members and leaders. So there's some specific tasks that you can do in dealing with resistance when they're amongst the members of the team within a clinic organization. A first step is sharing how that change is going to impact the team members within the organization, and that would involve leaders explaining that. So that would be the clinic team leader, that could be a clinic manager, the physician leader for the change, or members of the association. Importantly, in dealing with team members, they need to be involved in doing the work. So if they know that they have a stake in redesigning the work, that will help them get on board. They also need to know that they will be supported with training and mentoring. We've talked about changes in the EMR that may occur as a part of screening process redesign, and that might be new to members of the team. So they need to know that they'll be supported with training on how to use the EMR or mentoring on how to use the EMR. Now, when it comes to dealing with resistance of leaders within an organization, that would be the clinic manager, or it could be the physician leader. An important step is starting with open two-way dialogue. They need to be involved from the start and engaged. Also, you need to provide them with a toolbox so that they have tools that they can use throughout the change, and these are throughout your improvement facilitator binder that you can use. Make sure you involve the managers and leaders within the organization in all stages of the change. Of course, you want to be able to proactively deal with resistance, and that starts with clear and honest two-way communication. Early involvement of all team members, engaging the manager and the clinic leader, and engaging them with the clinic team members. Also, getting those clinic leaders on early and showing that they are prepared to help the team throughout the change. Some things that you really don't want to do include ignoring the resistance and expecting it to go away, not listening or not listening with understanding to the concerns of those impacted, not gaining input from those that are impacted amongst the clinic team, nor do you want to underestimate the resistance that might occur. So we're going to move along to a case study. As we move along to the case study, you might be thinking about questions that you have and can start sending in through the chat module. But Sandy's going to present a case study that she was involved with.
Okay, I think we're ready to go. So I just wanted to share with you a case study of a physician that I was involved in who was looking at screening in her practice, and she thought she did a wonderful job, but she heard some stats, and she heard that 1 of 4 adults that has hypertension, or 1 of 4 adults have hypertension, but a third didn't know that they had hypertension. That got her thinking. She heard that 60% of diabetics had gone a year without an exam, but she was pretty sure that didn't include her diabetic patients because she did do a good job of it. About 20% of heart failure patients are readmitted within 60 days. And she also read that less than 10% of those patients that had indications for colorectal cancer screening were being screened. So she thought she better have a look at her own practice. So her thought in the beginning was, I screen all of my patients at medicals. She also knew who her patients were, she thought. She spent a lot of time and effort trying to ensure that screening was done. And in her mind, she was doing a good job of providing chronic disease management. She knew she was working hard, and so to her, that equated to doing a great job. But she was getting bogged down. Okay. So she decided to do some measuring. So she discovered that she had 1,800 patients that were identified as her patients. She knew that she had encouraged patients to come yearly for complete medicals, at which she would do the screening. She knew she worked 300 days a year, but she also knew to keep her clinic day running smoothly that she could only book 2 medicals a day. So that meant 2 patients were being screened every day that she worked 300 days of the year. So she started to calculate that out, and she said, okay, so I have 300 days per year, 2 medicals. That means I can do 600 complete medicals per year. Wow. That was only 600 patients. What was happening to the other 1,200 patients? So what she discovered was that medicals, including screening, were only happening every 3 years for her patient panel. So she decided to measure a little bit more. So she looked at patients between the ages of 50 and 70, and discovered that those patients, female patients between 50 and 70, their mammograms were rate over the last 2 years were 54.8%. Her resistance was getting a little bit less, so she thought she would look at her patients that were receiving Pneumovax vaccines. So those were patients over the age of 65, and in October of 2007, those patients were 43% of her panel was getting that. So she really decided it was time to make some changes. Okay. So she started doing some process redesign within her office, and she went from 54.8%, measured again in November, went up to 77.7%, still was not happy with it, and eventually May 2010 sitting at 90%, and they're still maintaining it with the mammography rate. In Pneumovax, once again, the start in November of 2007 at 43%. In January of 2009, it was at 97.8%. And what she found out was also that 24 of those patients had declined the Pneumovax vaccine. So in summary, I just wanted to share her resistance to change was because she felt she was doing a good job, and her intent was to do a good job, to screen patients and keep on top of the chronic disease management in her office. She knew she was working hard, and what was the motivator for her was definitely the measurement. That was an eye-opener. And then her next barrier was, well, I may as well just give up. I can't do all of this myself. And so she started using those small tests of change to address what the team could do and how screening could be completed outside of the complete medical, which in ASaP we're referring to as opportunistic screening. So it was definitely interesting to watch her go through the hand up and I don't need to do any change because I'm doing a good job. There were obvious verbal cues, there were obvious nonverbal cues that she was very clear that this was part of her job as a physician, was to screen her patients, and that's what she was doing. And my hat is off to her for saying, okay, let's take it to this next step and do the measurement so that, and really her reason for doing the measurement was to prove that she was doing a good job. And so really what she was an eye-opener for her to be able to take it to that next step and recognize that this was not necessarily that she was a bad physician, but that she had to make some changes to do it different.
So at this point, just wondering if anybody that's listening has any questions. You can use your chat functionality that's on your display bar to send in some questions. So we have a question, and it was, how did you get her to agree to doing the measures? What reason did you give for doing them? Did she not feel threatened by doing them if she was convinced she was doing well already? Sandy, I know there's lots of questions there, so maybe handle them one at a time.
Okay, so I'll have a look at the first question. How did you get her to agree to measurement? So during the time that she was going through this change, she was also involved in AIM, and AIM became sort of her motivator for addressing the change, for addressing the measurement. She knew that it was time to start measuring. And I think the first measurement, when she figured out what her panel was and that she was only doing screening at complete medicals, that was an eye-opener for her, that measurement was very powerful, and it was actually her idea after that to go in and measure what the mammography rate and the Pneumovax rate was. So that kind of non-threatening measurement that, gee, I'm only doing 2 medicals a day, I'm only able to do 600 in a year, but I have 1,800 patients, was very eye-opening for her. So it was done in a very non-threatening way for her. What reason did you give for doing them? It was her idea. I think that's a art of facilitation right there, is to not tell her that she needed to measure, but guide her in the way so that she knew that she needed to measure, and in the end the measurement was her idea. Oh, and you're asking about feeling threatened. You know, I think physicians, like I said, really do want to do a good job, and they want to see that they're doing a good job. And this was a physician that was really ready for some change, and she was asking for that. So I think, once again, that's the facilitation, that you can just guide them in the direction, ask the questions. You know, do you know what your mammogram rates are? And ask some of those questions. Do you know how many of your patients are getting complete medicals? And she'd say, I don't really know the number. And so then, you know, say to her, would you like to measure? And so in the end, it is her decision to do that. Hope that helps.
Thank you. Those were great questions. Do we have any additional questions? If we don't have any additional questions at this time, we're going to go ahead and summarize. So what we talked about today, first of all, you do have some resources available to you. You have the IHI Open School courses. You have your book Facilitation at a Glance, which has a section on resistance to change. Your Improvement Facilitator Binder is another resource with multiple areas in there that you can find beneficial. Importantly, though, in moving ahead with a process redesign project, understand that resistance is natural and you should expect some degree of resistance. Importantly, though, early and effective two-way communication is a key for preventing resistance. So identify it and deal with it early. And as you move ahead, you have some tools in your toolbox that you can make available to yourself and the entire improvement team to deal with resistance as it may present throughout the project. Okay, so I'd like to sum up and thank you all for attending today. Wish you a good afternoon. If there are some follow-up discussions on this, we might be able to have it on our Yammer page. So have a great afternoon, everybody.